Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome to Universitas Airlangga Webinar Conference. I'm Dito Darlan, the host of Universitas Airlangga Conference. And now we will discuss it's about the pandemic COVID-19, War Against COVID-19. The pandemic is changing how we die, and not just for COVID-19 patients. As a headline by Time magazine 2 days ago, this is very true for us to be able to go through this pandemic this far. A new unexplained cluster of cases of pneumonia emerged in Wuhan, China on December 2019, and 2 months later, the World Health Organization, WHO, announced a new coronavirus strain worldwide. The time of pandemic has begun. The outbreak of the virus has sickened more than 4 million people. At least 280,000 people have died. Many of us, our fellow healthcare workers, had fallen to this virus. And now, more than 3,000 patients have deceased due to the virus in more than 200 countries worldwide. The drastic steps taken slowly to the spreading of COVID-19 are pushing out limit together as one humanity. We have never ever seen so closely by staying apart of each other. Around the world, it's important for us to lead the war against COVID-19. Every country has different way to resolve this problem based on their own resources, cultural, educational, and behavioral varieties of their citizens. Learning on how different countries overcome this crisis is essentially to help each other, gathering the important aspect to reach a better situation of the pandemic. Before we start our discussion, I want to inform that you can ask a question through the several feature by using raise hand feature to ask live question during the event, and or using a Q&A feature to ask by typing. But don't forget to introduce yourself. And also we inform you that this webinar is live on our YouTube channel. It's in Indonesia. You can click the icon on the upper left side. And now we have a great moderator that will lead our discussion. He is a neurovascular surgery for neurosurgery department, Dr. Sutomo Academic General Hospital, Surabaya. He is a member of Fellow American College Surgeon and International Fellow of American Association of Neurological Surgeon. Ladies and gentlemen, please welcome our great moderator, Dr. Asra Al Fauzi. The time is yours, Doctor.
Our distinguished speakers that willing to participate in this very important webinar conference. And of course, thank you, Professor Franco Servadei. Good morning. I think it's in Italy, still in the morning. Thank you for your willingness to share your experience in Italy about this pandemic. And also, good afternoon, Professor Ohata. Konnichiwa, Ohata Sensei. O genki desu ka? I think 4 years ago we last met here. And also all the Indonesian speakers, my mentor, Professor Djoko Santoso, Professor Nasronudin, the director of our hospital, also Dr. Joni Wahyuhadi, neurosurgeon, also the director of our hospital. Thank you for joining with us today. And we have a limited time, so as you already know, that the first speaker will be Professor Djoko Santoso. He will present about COVID-19, the morbidity and mortality. I think, please, Professor Djoko, time is yours.
Thank you, Dr. Asra. It's nice also. And good day, our speaker, especially Professor Kenji Ohata, also Professor Franco Servadei. And the second, I need to say about so much thank you, special thank you for Professor Kenji and Professor Franco. On behalf Chairman of Senate Academic Universitas Airlangga, I give special appreciate to you both for big contribution my university and international level. Once again, thank you so much for big contribution of my university. Okay, I start for the first slide is overview COVID-19 entitled Mortality and Morbidity, stressing of the overview. In this slide, is COVID-19 the first pandemic outbreak? I think, yes, this is slide. Sorry, and a little trouble for the my slide. Yeah, thank you. And this slide shows is COVID-19 the first pandemic outbreak? I think that my answer certainly no, because long years ago, the world has faced several large outbreaks that have almost killed humanity in enormous number called death toll. One of the outbreaks that is quite frightening is Black Plague or Black Death in 1300, which killed about 35% of European citizens at that time. Outbreak caused by bacterium Yersinia pestis and transmitted from the rat mites, making the global pandemic quite severe and caused tremendous fear throughout the world, especially Europe. Previously, found outbreak of antibiotic despair had enveloped the world in the medical field. In addition, outbreaks such as smallpox had also become global pandemic. But now, the last outbreak before COVID-19 experienced by humanity detail was the 2015 Ebola virus outbreak in Africa, which very killing and easily spread, especially in the Western Europe. And this slide, when referring the respiratory virus outbreak, the two most common viruses are influenza or orthomixture virus and coronavirus. You know, orthomixture virus has caused several outbreaks such as 1918, the Spanish flu, also in 1956, Asian flu, also Austrian flu in 1968, and 2003 bird flu, and 2009 swine flu. Coronavirus in 2002 until 2003 has caused outbreak in China and Hong Kong, and MERS virus in 2012 in Saudi Arabia. And the emergence of the new SARS-CoV-2 virus, which caused a global pandemic like just now. In the next slides, the first COVID was discovered on December 9, 2019, with persons who had symptoms of pneumonia. After that, on December 31st, in 2019, there are 41 people who had symptoms of pneumonia similar to the Huanan animal market in Wuhan. And the next day, the market is closed, and after 7 days, found a coronavirus called as novel coronavirus. And the first death was found on January 11, spread to other countries, was discovered in Thailand on January 13. In addition, the first death on 2nd February was found in the Philippines. From the graph above, the development of virus occurred exponentially and after strict intervention or lockdown. On January 23, only 1 month later, the curve is weakened. The total number of patients in China reached more 80,000 positive patients. The next slide will compare the case in China. The case in the world still show an exponential graph and has not shown any sign of curve sloping. This could symbolize the handling of each country. This is a less straight. In addition, there are no more than 100 countries infected with the virus. The COVID-19, which was initially estimated to have firstly R0 of around 2 to 2.3, but is now estimated to reach 5.1. This is because the possibility of the mutation and new strain of the virus from SARS-CoV-2 and poor self-distancing in some countries when compared with the other virus, such as measles. SARS-CoV-2 is not scary as measles that spread to 12 people, but because the chickenpox virus vaccine was discovered, herd immunity was formed soon. And the next slide, when compared with SARS in 2002, the MERS and the MERS 2012, these three viruses both originate from bats and spread through the second intermediate animal, namely civet on SARS, camels on MERS, and COVID-19 is thought to have spread the pangolin animal, which are believed to be used by residents of Wuhan and surrounding area as traditional medicine. When observed, SARS and MERS kill more with 99.6% and 43.4% mortality compared with COVID-19, which is only 3.7%. But due to spread of the SARS-CoV virus that was too fast, it caused very large death toll. In this overview, I try to formulate morbidity, healthcare management overview, public health policy overview, and at glance. I think you all know well about the structure of the viral. From in the envelope combined with the spike, which is there are glycoprotein membranes, and in the side, the RNA of the COVID-19. Strain of the virus, as I know until now, there are 3 strains of coronavirus, A, B, C. B type is dominantly in the Wuhan, but A or C at outside of the Wuhan. The type A referred to a strain of SARS-CoV-2, which originally found in Wuhan. It is similar genome to coronavirus in the bats and pangolins. After the single point mutation, SNP, the L strain type B appear and different character with more virulent and infectious. In the middle of February, there is a new Delta strain, L strain, that is different spike protein to bind its receptor. The virus is more infectious than before. That's mean this is coronavirus type 2. Spreading strain of the virus at the early period outbreak December, majority as the majority L strain is 70% and S strain is 30%, but S 3% is low infected. After that, mutation virus drove that in Europe and caused pandemic. Comparison coronavirus. The first origin comes from the bats, but in here it's intermediates of animal, but the last is the human. Name disease of the virus, major symptom mostly almost of the same in the respiratory tract, but different in the others, especially in the coronavirus 2, because dominantly is bind receptor of the H2 receptor. So it's a great opportunity related with all the organ, because it's a two receptor dominantly in the body. This SARS, MERS, and COVID. If we pay attention about in these slides, first reported China telling about the SARS, infectious 8,000 blah blah blah, the deaths only 700 blah blah blah. But in the COVID-19 until now 4 million more, the death more 200,000 deaths. Because of that, I caught not only the virus enough, but it's a super virus. Related with the impact of the body, dominantly COVID-19 in the respiratory disorders, included the more than symptoms like rhino sneezing, pneumonia, when we check of the CT scan and a ground glass opacity, when the check in the viral loads, I think so more viral. But not only the respiratory disorder attack, but also the systemic disorder. Like I just say about related with its receptor 2. Mortality and morbidity. Please check in this slide. In the USA, 1 week ago, or 2 weeks ago, the total and 1,000 more, 1 million more. Oh, sorry, the deaths. I think check, yeah. This is one infections. In the deaths is 1,000 more, and Indonesia in 14,000 infectious cases. And the deaths more than 900. Comparison between what in Indonesia and total in the Indonesia infected cases 14,000 more, but in the world more than 4 millions, and recovered in my country approximately 3,000 more, and recovered in the global more than 1.5 million. This is the picture, new reported case by day across the world. This picture like this until the May. Even though if we look at the graph, the mortality rate has shown a declining trend, but the daily mortality rate is still high, around 5,000 cases of death every day. There are several countries that show a number of new cases. They are still increasing, like South Korea. 2-minute slides. In this slide also, several countries that show a number of new cases that are still increasing. Also, this picture is decline. And Indonesia still shows stable number, positive every day. This possible because the tests have not been comprehensive. This like in Indonesia, this is a curve of the cases. The death cause are most like the same in the world, start from respiratory until the cardiogenic shocks. Risk factor mortality depend on host, agent, and environment. Especially host is the age, also underlying disease is sex and sex, agents, spread of viral so fastly, and environment, urbanization, and disobey of the regulation. And the risk factor like this are more than 50, and the male is dominant be compared to the female. Pre-existing like this, and comorbid correlated COVID-19 like this. Yes, Indonesia until now not show of the data. Health management in Wuhan, I think you know well about how to build the hospital, new hospital. Wuhan healthcare management is locked down, but until now is free from the case. Indonesia management and all hospital capable to take care of the COVID patient. Until now, 133. I think Dr. Joni will mention it. Surveillance study in Indonesia, ODP and BDP is principally it's a strict for the physical distancing. People under monitoring, VS patient under surveillance. Vietnam is so interesting about strategy of management of the COVID because the case zero. Vietnam government declared war to the virus even before the COVID entering the country. While only 10 cases in February, but after no cases. Screening in the Vietnam, I think it's need to adopt in each of the country. I think as suitable with the background of the local conditions. Public health hospital policy, I think Dr. Joni will mention it. Lockdown in Wuhan like this, the conditions so quiet. This 6-period intervention on Wuhan start from 8 December and the last in the 7 April after 17 days and 2,500 deaths. The lockdown is been lifted, but now appear again. Indonesia public policy like this, large-scale social restriction until now. Taiwan respond so interest like the Vietnam because Taiwan implemented towards hit by SARS outbreak like the 2003. Government took over face mask production to ensure the local supply. Take home message. 2003 China, Hong Kong. 2012 Saudi Arabia related to Moscow. And 2019 is SARS-CoV-2 like now, just now. So I hope, even though until now our vaccine not fastly appear, discover, but I hope a half year or 1 year, the vaccine discover fastly. Thank you so much.
Thank you, Professor, for your nice presentation. And we will discuss later after the first session. And the second speaker will be Professor Nasronudin, and he will talk about the COVID-19 and herd immunity, because it's very important for us to know about this. Please, Professor Nasrun.
Okay.
Please, Professor Nasrun. Yeah.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, Honorable Moderator and all speakers, all professor and all senior, and also ladies and gentlemen. Today, I would like to present my topic is about COVID-19 and herd immunity. COVID-19 is a novel infectious disease, as well as other emerging infectious disease. Firstly, even in Wuhan, China, at the end of 2019, when the SARS-CoV started to spread from China to other countries, particularly nobody was immune. The disease is highly infectious and spreads from human to human through droplets. Currently, in the ongoing SARS-CoV-2 pandemic, over than 200 countries has reported this disease and has caused over than 4 million infected confirmed cases COVID-19 in worldwide. Next. The picture reveals that situation and number by WHO region and globally now over than 4 million people infected. And the most prevalent still in United States of America and also in several countries in Europe. The case fatality rates seem to depend heavy of disease and the quality of treatment, and is currently estimated to be 1.4 and 5% or more in several countries. The SARS-CoV-2 pandemic spread throughout the world. Doctors, scientists, and government leaders alike have said that once herd immunity was achieved, the spread of the virus would be less of threat. Herd immunity is reached when the majority of given population, 67% or more, becomes immune to COVID-19, either because they have become infected and recover or through vaccination. When that happens, the disease is less likely to spread to people because there just enough infections to reach. What is herd immunity and can it to stop COVID-19? There are basically 3 ways to stop the COVID-19. This one involves extraordinary restriction on free movement and assembly, as well as aggressive testing to interrupt its transmission entirely. And the second is a vaccine that could protect everyone, but it still needs to be developed in under 12 months or more. And the third is potentially effective herd immunity, but horrible to consider. Just with under enough people getting build up some kind of herd immunity, show more people are immune to SARS-CoV-2, and we reduce the transmission. This COVID-19 virus can end up after infecting about 60 to 70% of the world's population. Herd immunity of COVID-19 goal or outcome. Herd immunity is the indirect protection from contagious infectious disease. This happens when a population is immune either through vaccination or immunity developed through previous infection. Herd immunity should be achieved when around 60 to 70% of the population becomes immune to COVID-19. Natural herd immunity can be achieved through infection rather than vaccination. It can be challenging task as there would be a very high risk of serious illness or deaths. Furthermore, there will be an overwhelmed health system beyond the research capacity. This question is it possible to stop COVID-19 with herd immunity? Herd immunity, COVID-19 always depend on the vaccine without vaccine. The potential herd COVID-19 if herd immunity is achieved in the absence of vaccination. The SARS-CoV-2 spread more easily if without vaccination. Next. What is herd immunity? How it's work? Without immunization and with immunization. If without immunization, if some gets vaccinated, the virus easily spreads. And with immunization, the virus easily spreads, but the virus is contained. Assuming herd immunity is established of uniform threshold of 67% in each country, with case fatality rates 1.4 to 5% or more in several countries. While the variation in transmissibility between individuals may play a major role in SARS-CoV-2 spreads. Finally, the factors that influence inter-individual heterogeneity in COVID-19 susceptibility, clinical pathology, and disease outcome are not well understood. The picture reveals that if no is immunized, contagious disease spread through the population for more easy. Some of the population gets immunized. Contagious disease spreads through some of the population. And if most of the population gets immunized, spread of contagious disease is contained. COVID-19 versus herd immunity and case fatality rates. The question, if in the worldwide only depend on the herd immunity, based on theory of herd immunity thresholds, COVID-19 ranks 29 to 75%. If minimal 29% of worldwide should be infected, or around 2.2 billion people, and if 3% case fatality rate, so average 66 million or more people would die. Herd immunity by infection is not without risk. Most doctors and experts agree that allowing COVID-19 to just flow through population might help reach herd immunity more quickly. But that would also overwhelm hospitals. More people would die, not just from coronavirus, but also from other infections too. So a vaccine is better unsure. Recently, more scientists and developers come together to work globally and to advantage a vaccine. Herd immunity and SARS-CoV-2. The ongoing SARS-CoV-2 pandemic has caused over 4 million clinically confirmed cases of COVID-19. Numerous clinical trials to evaluate novel vaccine candidates and drugs research strategy for the prevention and treatment of SARS-CoV-2 infection are currently ongoing. However, it is unclear how long the study will take to establish efficacy and safety. And optimistic estimates for any vaccine trial in at least 12 to 18 months. In the absence of vaccine, building up SARS-CoV-2 herd immunity through natural infection is theoretically possible. A sign onset of SARS-CoV-2 spreads. Various studies have estimated the basic reproductive number of the virus to be a range of 2 to 6. This variation reflects that the difficulty of obtaining accurate basic reproductive number estimates in an ongoing pandemic not always indicates a complete picture of transmission dynamic across all countries. Assuming a basic reproductive number estimate of 3 for SARS-CoV-2, the herd immunity threshold is approximately 6-7%. Consequences of raising the SARS-CoV-2 herd immunity threshold is the absence of vaccine. One important measure to evaluate the impacts of SARS-CoV-2 spread is overall case fatality rates. It is worth nothing that there are still significant uncertainties in the case fatality rate for COVID-19 due to variation in the testing capacity per country, selection bias for which individual receive testing, and differences in how deaths are officially attributed to COVID-19. Further, case fatality rates is also sensitive to variation in the underlying age structure and distribution of comorbidities among population. Next. Consequently, case fatality rates may differ considerably over time and between countries. The spread of SARS-CoV-2 will rapidly overwhelm healthcare system. A depletion in healthcare resources will not only lead to elevated COVID-19 mortality, but also to increase all-cause mortality. In summary, there are basically 3 possible approaches to widespread SARS-CoV-2 immunity. This one is a mass vaccination campaign, which requires the development of an effective and safe vaccine. And the second, natural immunization of local population with the virus over time or herd immunity. And the third, involves extraordinary restriction of free movement and assembly, as well as aggressive testing to interrupt its transmission entirely. However, the consequences is the latter infected with the virus and millions would succumb to it. The absence of vaccination program establishing herd immunity should not the ultimate goal. The physical distancing measure needed may vary over time and will not always need to be as strict as our current shelter-in-place law, maybe through 2021 and 2022. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh. Thank you very much, Prof Nasron. You explained to us very clear about what is herd immunity and how it's involved in future progress of this pandemic. Thank you very much. And then the next speaker will be Professor Franco Servadei from Milano, Italy. Please, Franco, time is yours.
Hello, Asra. Hello,
Yes.
all my Indonesian friend. Hello, Afid Bajamal, my neurosurgeon friend. Hello to the staff of the Airlangga University. Thank them to organizing this meeting. We had, as the World Federation, we had many meetings around the world already. We had meetings in Europe, in America. We will have a meeting next week in Africa. So I think it's a terrible problem that we are facing now. I will try to give you the experience we had in Milano, which was the first hit area outside China. We live in a region of 10 million people. Asra, can you hear me and you see the screen? Is it okay? Can you see my screen?
It's very
Yes,
good.
yes,
It's very
yes.
good, sir.
Okay, let's go. So we had a terrible experience, so I'm going to share it with you. The first slide, which also have one Indonesian woman, is in honor of 5 eminent neurosurgeons who died because of the virus in Indonesia, in the US, in China, in Spain, so in India. So all over the world, we have victims of the virus in doctors and in neurosurgeons. You have already seen these slides. I tell you that if you look at the mortality per population, you see it in this. In Europe, you see that there are similar data, unfortunately, in Spain, in France, in UK, in Italy, in France, Belgium, and Netherlands. So we have a tremendously unexpected high mortality at the beginning only in Italy. So we thought it's an Italian problem, but it's not. 5 European countries have a mortality exceeding 10% of the tested people. No one would expect it after the data from China, but this is the European average. Unfortunately, it's not Italy, it's 5, 6 countries. You see that there are countries like Russia, or like, you see it here, less Germany, but also Iran or Turkey, where the mortality is unexpectedly much lower. We'll discuss it. This is comparing mortality and mean age of the population. As you see, we have the oldest mean age of population in the world. We are second only to Japan. So our population is old. And you see it here, the countries with more deaths, like Spain, United Kingdom, and France, are all in this area, where the mean age of the population is very high. If you look at the Italian data, you see the age of people dying because of the virus. Most of the people is between 70 and 79 and between 80 and 89. In my country, the mean age of people who is positive to virus is 61 years. The mean age of people dying because of the virus is 80 years. So the population of dying is old, and they have at least 2 comorbidities. You see, this is the list of comorbidities they have: ischemic heart, fibrillation, stroke, hypertension, diabetes, dementia, cancer, liver, renal failure, and 73% have at least 2 comorbidities. So the mean age of people dying is 80 years, and the mean comorbidity is 2 comorbidities. So it's a population who is a spectrum of the European population. When I was visiting Indonesia, you remember, we see that in our country, the mean cause of trauma is fall in elderly people. In your country is car crash accidents. Our populations are different. And what you have to know, it's how do you count the number of deaths? I will be critical in some part of my presentation, but I think if we want to discuss it, we need to see what we have done wrong and what is wrong around the world. You know, there are only 4 countries in the world, Italy, Spain, France, and UK, who are counting as COVID deaths the people dying at home or in places where the old people are cared for, and we perform swab test after death. So if the people dies, then we check if they have COVID afterwards. If you don't do it, then you cannot attribute this death to the COVID. And these change the numbers. In my country is 35%. So 35% of people dying, the diagnosis is post-mortem. It's not before, because they are very old. Then we have to understand that we have to tell the truth. I must be clear. In China, they have corrected the number of people dying for coronavirus 3 times, changing the numbers. In many countries, I can give you at least 10 examples. The data for mortality are released after the government check the data. In Europe, no. Every day we have an independent medical body who is called the National Healthcare Institute who released the date, and the government has nothing to do. There are countries where the data on mortality are checked twice, 3 times, and this is important. What about neurosurgery? We are neurosurgeons. How did we deal with the COVID when it arrived? There are, you see, if you look at the publication, not only in neurosurgery, in any kind of surgery, there are advice already published. How do you deal with the situation of COVID? You see, this is a typical advice, how to do it. Stop elective surgery, do only emergency surgery, stop clinic consulting, stop conference, reduce the number of residents, or even very clear in 4 steps. You see, depending in connection with the number of infected people you have, you change your policy and you move to another step. But we have seen it, but practically we couldn't do anything. I show you why. When you have a tsunami, you cannot prevent anything, because you don't have time. Our experience is like in Italy at the beginning, in the area where we are, in Milano, we had a tsunami. I give you an example. For about 7 days, we had 15 people coming to our emergency department with respiratory insufficiency related to COVID. In one night, we had 70, and the day after, 100. It's like a tsunami. So in the night, we have to work, stop all the operating theaters, and transform everything we had, where we had ventilators, into ICU. We have changed the availability of ICU in our region, in Lombardy, from 700 to 2,000 in almost 2 weeks only. So we change everything. And in my hospital, we reached 400 beds for COVID and 100 beds of ICU, and every hospital was the same. So we were like hit by something we will never expect. And so we have to reconvert every ward into pneumology, reconvert every ICU into ICU. How did we keep neurosurgery and surgery, generally speaking, working? We have published our experience in the Journal of Neurosurgery. What we have done is an editorial that we wrote for the journal, for the Americans, for the Journal of Neurosurgery. What we have done is reducing the number of neurosurgery from about 12 to 3 only 3 neurosurgical units open in the area, only 3 for 10 million people. But these 3 units were, we concentrated neurosurgeons there. So we moved our neurosurgeon only to 3 places where we send all the cases to be operated. And also we moved 2 more patients to these places, and we moved there to operate. We couldn't keep neurosurgical units open. So we centralized our patients and we moved neurosurgeons. There are general suggestions for treatment. You see that there are many. This is the American College of Surgeons. We already heard, so I will go quickly. There is a very nice website from the Society of British Neurosurgeons. Mainly in our work, the main problems are during intubation and extubation, during surgeries, which expose the respiratory tract like and high-speed drills where we have the spread of the virus. So there have been a lot of discussion about endonasal procedures. You see it here. You see it. So the main thing is whenever you have a patient who is positive, you have to wait. And if possible, change procedure. Do it intracranially or do it through another way or just use a waiting list because this is terribly risky. Then this is the proposal from Singapore, but you see it here, you cannot operate if you are like this. It's very difficult. Whenever you use the PAPR protection, which is this one, it's impossible to operate. For us, we have tried, it's impossible. So you cannot use a microscope. The endoscope is difficult to use. So this is the experience of our colleagues in Cambridge who did some operation and they didn't get problems, but they had a lot of protection and safety during surgery. The other thing is always when we talk about a patient in the COVID area and in the COVID times, if you can do in a neuro-oncology patient a test, it's always much better because when you have done a test, you divide the patient into two parts. One part who is negative, most of our patients, one part who is positive. And obviously, what we have learned is the indication for surgery, not only neurosurgery, will change dramatically because if the patient has a brain metastasis and can be treated with radiotherapy and is COVID positive, we don't do any surgery. So it's different. And this is what we are doing. These are 12 of my colleagues, including myself. We always, every Monday, we discuss the cases who are positive to see together if we have to operate or not. And this is for cerebrovascular procedure. This is for spine procedure. You see that being published a lot. But our experience is that whenever you have a storm or COVID, the degenerative spine can wait. And we obviously operate spine tumors and spine trauma. And this is, you see it, is a letter sent from our colleagues about the spine surgery. We just go how to protect the neurosurgeons and surgeons generally. You saw the experience of our Chinese colleagues, you see it here, was that they had a lot of infected medical professionals in neurosurgery because of no protection. And they have calculated that the risk of an infection of COVID, you see it here, it's much more if the exposition to patient is longer. So what they have advised us is that you shorten the time to visit the patients and you use protecting mask and face shields. You see, this has been shown to be, the combination between mask and shields has been shown to be appropriate. So the Chinese now say that if you want to operate in safety, the patients, you have to do a test 5 days before and 1 day before surgery. This is impossible for us. because we cannot keep the patient in the hospital for 5 days waiting for surgery. So what we are doing is out-hospital test. If the test is negative, on admission, we do a chest X-ray. So what we are doing is a combination of swab and chest X-ray. We use N95 protections, and unfortunately, at the beginning, in Italy and Spain, 10% of the positive patients were working in the hospital. So we had a very high exposure in the hospital, and the mistake was to test only patients who were symptomatic. We learned that many patients in the asymptomatic phase can infect us. So the last is many of neurosurgeons and surgeons were transformed into pneumologists. You see it here, the experience of my colleagues. Almost all the staff was transferred to working in COVID patients. And they got a quick, this is our pneumologist, they got a quick refresh how to use a pulmonary device, and our young neurosurgeon, they made a very good job. So which are the new suggestions? When I want to be practical with you, we have made many mistakes. So what can we learn from our experience? We have done a tremendous mistake at the beginning. We told everyone who has only fever to wait at home and see how does it work. And many of these patients came with respiratory insufficiency too late. We wait too much. So we need many intubation for these patients, and the mortality was very high. So now we treat them at home or in the hospital after the first step of the disease with anti-inflammatory drugs like Chloroquine or the new tocilizumab, any drug plus heparin. I will show you why heparin. Whenever the oximetry showed you SO2 less than 90, let's say 92, then the patient, even without symptoms, is admitted to the hospital. So these are decreased a lot of the number of patients we send to hospital admission in ICU. So we treat them before. Then we have discovered by doing autopsies, this is 100 autopsies done in Italy, we discovered that together with pneumonia, there is a lung infarction. There are a lot of thrombosis in the lung, microthrombosis. Almost every patient who died has a lot of microthrombosis. So we started to treat our patients with heparin, low-weight heparin from the beginning. So what we are doing now is we start again to do surgery. We start again to do tests before admission to our patients. And we did a serum test to all hospital workers to start it again. This is the rules to return to work. In conclusion, I give you some message, positive message. We are not a separate body. All the doctors are the same. Neurosurgeons can work as pneumologists with good results. We can intubate, we can learn how to help our colleagues who are not enough to treat all the patients. Then we also show that we are able to reorganize our service and to keep neurosurgery working even in difficult situations. We also learned, like today, that some meetings can be done by remote with very good results. We have also positively to learn that the Latins say mater artium necessitas. So the mother of science, and as our Indonesian colleagues showed before, the mother of every discovery is the need. So now we have a terrible need to cure our patients, and we have a terrible need to find a vaccine. And we are all working in the world for that. So we are the same. We thought before that the virus is only in China, we will never get in Europe, and we got it. Then we thought, well, maybe we have too many deaths because people is old. And then we discovered that the Europe was the same. Then now the virus is everywhere. So we have a common feeling and a common strong feeling about finding the way to treat this patient, taking them seriously. I told in my country, the mortality, like in Europe, is around 10% of those one who have been tested. So it's very high. We have to take this virus seriously. And just to give you an hope, this is the loop, the curve of the infected people in Italy, and this is the curve of people dying. So you see, it's going down. So we after next Monday, we will finish our lockdown. We will open the activities, and we are worried about what it will happen, but the life has to continue. Thank you very much for your attention.
For your beautiful presentation. And I think we now the end of the first session. So it is now a question and answer and discussion. And please, Prof Rita, if you have any comment or question. Professor Rita, please. Professor Rita is there. Maybe Dr. Brahmana. Please, Dr. Brahmana, if you have any comment or question.
Thank you very much for the chairman.
Okay, please.
Oh, I'm late. Okay.
Prof Rita, please.
I just
It's going
okay.
to be for okay.
Okay, Prof Rita, please. Yeah. If you have any comment or question, please.
Thank you. First, I have comment and question as well. First, for Professor Nasronudin. Yes, you told us about the herd immunity. I just read about the, reconvalescence exchange transfusion of plasma with the patient that just recover from COVID, and they just take the plasma and transfuse to other patient because it is raised with the antibody. How do you think about this type of treatment? They already do it in the RSPAD, and I think it's already done in outside Indonesia. How do you think about just transfer the antibody, the plasma with so rich antibody to another patient? It is for Professor Nasronudin. I think I have to open my mask. Can you just hear me?
Yes, we can hear you.
Yeah, okay.
Please, Professor Nasrun, you can answer the first question.
Thank you very much to Professor Rita for your nice question. About reconvalescent transfusion of plasma, I think is a nice strategy for treatment in COVID-19, because SARS-CoV-2 causing COVID-19, someone is infected by COVID-19 based on defect on immune system. So the most people infected by COVID-19 is with co-infection or co-basic disease, especially in diabetes mellitus, hypertension, chronic renal disease, HIV, and the autoimmune disease, and the other. So reconvalescent plasma is very nice, and I think it's need for therapy in COVID-19, especially in severe disease. So in the convalescent plasma have antibody and someone or a patient need to support for antibody. So we support to therapy about reconvalescent plasma, Professor Rita.
Thank you, because vaccine need 8 to 12 months, Prof. It's a long time, and most quickly with more quickly with the antibody from plasma. And then can I ask again to Professor Franco?
Okay, please.
Yeah, Prof. Franco, I appreciate your statement about first doctors and then surgeon, because sometimes we just isolated us in our discipline only, the specialists. But in Indonesia, we have a special decree from the medical council that just what, like you say, mentioned that doctor is doctors, even though he or she is a neurosurgeon or an anesthesiologist. So we get more and more doctors to just prevent and cure the COVID. And then about the telemedicine, do you use the telemedicine just to emphasize the physical distancing in Italy, to diagnose and to treat the patient?
Okay, Franco. Franco.
Unmute.
Muted.
Not
Now
yet.
it's
Okay.
now,
Yeah, okay.
okay. Sorry. The first, I was surprised. If 3 months ago or 4 months ago, I would ask one of my young coworkers, will you be able to ventilate the patient, to check oxygenation and to do therapy for pneumology? They will only laugh and say, you are crazy. We will not be able. But after just 3 weeks of intensive course, all of our young neurosurgeons for about 1.5 months work with COVID patient with all protections and work in a team together with pneumologists, and they did a very good job. So I think we can do it. That's not so difficult. We need a retraining, but the retraining is quick. It's only 1 week. And about telemedicine, yes, we have used a lot telemedicine. As you have seen, I showed you 10 cases, and then we discuss with us how to do it, and then we call the patients and speak with the patient via telemedicine and explain the risk and the benefit of surgery. So yes, telemedicine is a good choice for us and for all of us to work. Then I had a question from a chat about chloroquine, because we use chloroquine. Obviously, as a premise, there is no proved drug. There are no enough trials to demonstrate that chloroquine works, tovicidumab works, anything works. We don't have it, so it's only compassionate. Chloroquine has, we have found that chloroquine has only one problem, is QT abnormal lengths in the electrocardiography. So you must be very careful with patients with cardiopathy and with problems in the cardiac area. That's the only thing we have found.
Yes. Thank you. I'm done, Dr. Asra. Back to you.
Yes, thank you, Professor. Dr. Brahmana, you have comment or question, please.
First, I would like to address my question to Prof. Djoko Santoso, and then it was a great and excellent presentation. And why does the mortality rates differ across the countries, and what the most dominant factor that may cause the difference? Perhaps this question, Prof. Djoko Santoso.
knowledge, each of the country have a special background. So consequently, any different different number of the mortality rates, like Indonesia and Europe, also in the Australia and the United States. We know, we just here come from the newspaper. Indonesia strain so different with the Europe also and the United States. The different strains have a consequently for the different for the mortality rates. Because of that, if each country have good data of the sequencing of the whole genome, this is so important to make a formulation to anticipate for the COVID pandemic. I think that's all.
Thank you. Can I add something to the mortality?
Yes.
Okay.
That, as I've shown you, it depends on how you count. I don't tell you that you have to count people as we are doing, because you need a lot of tests. If you don't have so many tests, you cannot do it. So the first thing, you cannot compare pear and apples. In my country, in Europe, 40% are post-mortem, 30 to 40. It's in countries where you don't have enough tests, you cannot do it. So I am telling you, not that we are doing the right. When you look at our numbers, you have to know where they come from. This is one thing which is important. The second thing about mortality is we are publishing now in Bergamo, who is the Italian city most affected by COVID. In one small city, we have more than 1,500 deaths. The city was hit by COVID tremendously. There is a large Indian community from India. Only 3 people died from the Indian side. So there must be something that we don't know, probably related to vaccinations, probably related to genetics. I don't know. We are studying. All the Germans are doing studies, but there must be something, because this population was exposed exactly like the Italians in the same place, but they get much more death. So much less death than we did. So we don't know. At the moment, I don't know, basically.
Yeah. Thank you for your session.
Thank you.
And a
Professor
second question.
Okay. Dr. Brahmana, you have any comment?
It was an excellent presentation.
Yes.
And then I would like to have a comment from Professor Nasronudin, how to implement herd immunity approach to stop virus without Is it clear, Dr. Asra?
Okay, can you hear? Yes. Prof Nasrun, you can understand?
Yes.
The question
okay,
from okay,
about,
please.
About management of COVID-19, optimal is based on vaccine and drug of therapy.
Okay.
Because vaccine and drug therapy until now is still ongoing, so need time is more time. So we must to follow about Indonesian government protocol. So physical distancing, assembly, discipline, and hygiene, and the other. I think that's very, very important to herd immunity. To need herd immunity, because if we are depend on herd immunity, it's very dangerous. So based on basic reproductive number, if one person positive COVID-19 can to spread to 2% to potential in population 50% of member of population were infected and high risk for her sir. So I think is vaccine and treatment drug of choice is good answer. Thank you very much.
Thank you very much, Prof. Nasronudin. Can I have one more question, Dr. Asra,
Okay,
to
please,
Professor
please.
Franco? The last one to Professor Franco.
Yeah.
I can imagine how severe is the disruption in the care for the non-COVID patient. And then, in your opinion, is there any importance to allocate the hospital just dedicated for non-COVID patient?
Yeah, you are right. This is the key question. We had no time because of the tsunami to divide hospital into COVID and non-COVID. We were merged by so many patients. Now we are doing it. So we start reoperating on, at the moment, for instance, we work 60% of our capacity. While we start again operating tumors, operating spine, we start again operating general surgery, anything in safety, and we divided the hospital into two different parts with two different tracks, not communicating one each other, one COVID and one non-COVID. But at the beginning, it was such a mess that we only divided COVID patients who were symptomatic. All the other patients were not tested. And the result was that we were overwhelmed by patients who were non-COVID who became COVID, and they infected everyone. So this was a terrible mistake. Now we are working on two different parts of the hospital, and our governments for the future wants to have different hospitals, the COVID hospitals and non-COVID hospitals. But this requires time. It requires time. But you know, in my country, we started with 5,000 beds of ICU all over the country of intensive care medicine. Now we have 13,000. So in 1 month, we moved to 5,000 to 13,000. You can understand how big was the effort. We had to do everything we could. But the solution is keeping in two different parts. You're right.
Okay. Okay. Thank you very much, Prof. Thank you.
Thank you, Dr. Brahmana. I think the time is running out, so maybe we have to end this session. Thank you for the speaker. And we move to next speaker. So there will be Professor Kenji Ohata from Japan. Please, you can start your presentation.
I hope you can see my slide and you can hear my voice.
Okay.
Okay.
Please.
So, thank you very much for inviting me to this conference. So I'm really proud to talk about our experience regarding the COVID. So. Okay, so first I would like to show the, let me change. First I'd like to show the coronavirus infection in Japan. So after Chinese outbreak, we began to have the patient February, and it's become prominent at the end of March. So government declared the state of emergency on April 7th. We all Japanese people thought this is too late. And what we did is stay home movement. And so what we must do is stay home. We cancel all our conference, we cancel all meetings, and we are completely isolated at home. I stay in my office for 8 hours like that. And this is a flyer from the government. So there's several three things prohibited: closed space, and crowd spaces, and close contact setting. So we avoid these three C's. And so the risk of the occurrence of the cluster is particularly high when we see three C's overlapped. Even before this state of the emergency, we already start to stay at home. This is a photo as a restaurant area in the Osaka, center part of Osaka. There's no people on the street. And April 17th, there's the photo of the main railway station. There's so few people on the station. So what happened after the stay at home is, so we had, I think, a peak off of the infection, and the state of emergency lifted in 34 prefectures out of 47, except for a special alert area, including Tokyo and Osaka. So this, the infection specialists are saying that these two small peaks were due to the clusters in hospital and care homes. And this slide showing the deaths in total and the clinical cause of the COVID. Of course, total number of the deaths is increasing, but the right graphic showing that the recovered cases become nearly same as the infected case on March 12th. It may be reasonable to say we had the peak off of the COVID. So this slide showing the clinical cause by age group. Ages, any ages are affected by this virus, and elderly people tend to have the infection at high rate. So diagnostic testing by PCR is not enough high in Japan. At most, 12,000 tests were done in one day. There's so many discussion on this PCR testing in Japan. So this is COVID world mapping as compared to the US and the European countries. Our infection rate is very low. And this is a death world mapping as compared to the US and Europe. Our mortality is low. It's same as in Indonesia, I guess. And this slide is showing the confirmed deaths per million people. It's provided by Sapporo Medical University. This is difficult to see. So this is Japan. Mortality rate of Japan is quite low as compared to other countries. So there are many possible reasons. We start to think why we have such low mortality rate in Japan. There is several arguments about this. Nobody knows the reality. And one reason is the healthcare system in Japan. And the other is second is a traditional lifestyle. And the third is national mandatory BCG vaccination program. So I want to show each thought. So this is a healthcare system in Japan. We have, this is a hospital bed per 1,000 population in each country. Can you hear me? This is Canada. This is Japan. Japan has so many hospital beds as compared to other countries. It's the same as Germany. And this is very unique as compared to other countries. So this is a hospital where I'm working. This is an institute consisted of hospital and care home. So at the entrance, one who enters the institution must have check the fever and must prescribe the hand with alcohol. This is a building of the hospital complex, hospital and care home complex. This is now become tradition in Japan. So this is the Social Medical Corporation Kodokai I'm belonging to now. And this is, they have 4 hospitals, including 600 beds and 70 care home, including nearly 1,000 beds. These elderly people staying in the care home has under the control with sophisticated medical safetyness. This is very important. Very important. The elderly people just staying at the care home has a high quality of the medical service. So mortality in elderly facility is low in Japan. This is a number of COVID-related confirmed deaths in population and in care home in the world. If you look at Australia, so total number of deaths linked to the COVID is 95, and the number of deaths care home less than linked to COVID is 24. So number of the care home resident deaths as percent of the all COVID patient are 25%. This is really high, really high. In Japan, this rate is just 12%. It's meaning the elderly people staying in care home has a really good treatment. They death, of course, 10% of the people dying. But this is a very, very important factor why we have such good mortality, better mortality rate in Japan. So this is another reason we are discussing, but nobody knows the reality. This is maybe somebody mentions, depend on the country, the mortality rate is quite low. So this is our system, National Mandatory BCG Vaccination Program. This is already published in Nature and Lancet and Allergy, the famous paper published currently. So this is a slide describing relation between BCG and mortality of COVID infection. If you look at this group, these countries, Taiwan, Iraq, Japan, Korea, China, they have BCG continuation with a very, very quite low mortality as compared to the other country where BCG ended or BCG no program. They are so quite high mortality rate. So I think somebody is thinking BCG may have a good immune to the people. So now I move on to what we are doing to treat the patient. So this is a guideline of the Otorhinolaryngology Society of Japan. This is a very, very complicated Excel. So I try to simplify the guideline. So this is a recommendation action of non-elective case surgery. So of course we must wait if possible. So if PCR available, we test the patient. If the negative, surgery should be done with standard PPE. If test is positive, there's several ways to do for the patient. First is a prioritized COVID treatment, of course, and postpone surgery, and surgery with full PPE or alternative treatment, including radiation therapy or like that. So, but the problem is PCR test has quite low sensitivity. Sensitivity is 50 to 70%. Specificity is just about 99%. It is quite low. So we are still wondering we may follow this test result. So if the test is PCR is not available, And this guideline separates low-risk area patients, such as in the countryside, and high-risk area, such as Tokyo and Osaka. In high-risk area, patients are asked to stay at home for 2 weeks, and then patient has a chest CT scan. Fortunately, we have so many CT scans in Japan. So patient has a CT scan, and this is a negative. Surgery with standard PPE is recommended. If this is a positive, patient has a has a COVID infection. So patient, we must prioritize treatment and postpone operation and the surgery with full PPE, or we must select alternative treatment. So this is diagnostic testing PCR for COVID patient in OECD countries. So interestingly, unfortunately, I want to say I'm happy or unhappy. So number of the PCR tests in Japan is very, very low as compared to other countries. There's a big debate about this. Now, why PCR test is few in Japan is first, sensitivity and specificity is not high enough. And the second is not all medical institutions can collect specimens. And third, lack of equipment and reagent. And fourth, limited human resources with experience and knowledge. But now pharmaceutical company now developing the better PCR testing system. So we hope this number may be getting increased. So regarding the CT scan test is routine for the patient who has operation. After the admission, patient must have a CT scan. This is a graph of the distribution of CT scan in each country. If you look at this line, Japanese CT scan is so sky high. We have so many CT scan incidentally. So we have many CT scan to scan the patient. It's I think very definitive way to know the patient infection. So this is my last slide. So we fortunately have a peak off in Japan. Many people are thinking, many people are glad to go outside, but all people are afraid of the second wave of the coronavirus. So we are wondering how to treat and live together with COVID. So thank you very much for your attention.
The experience in Japan, I think, is very much different from other countries, especially from Indonesia too. We will discuss more in the last of the session, and we will go ahead to the last presentation. Will be Dr. Joni Wahyuhadi. He is our director of our hospital, and he is one of the key person in our country managing this pandemic. Please,
Asra, can I say hello?
Thank you. Yeah.
Hello.
Okay. Okay. Thank you.
Can I say hello to all of you?
Okay. Please, Franco.
Thank you so much for the very nice meeting, and we keep in touch. Thank you, all of you. Sorry.
Okay, thank you. Bye.
Thank you
Thank
very
you.
much, Professor. Thank you, Franco. Thank you very much.
Please, Dr. Joni, you can start.
Thank you very much, Dr. Asra, as a moderator of the sessions. Thank you very much, Professor Franco, Professor Kenji Ohata, Professor Djoko, and Professor Nasronudin, Professor Hafid, Professor Rita, Dr. Brahmana, and all of the participants in the sessions. I would like to present about how to handling of the COVID-19 in East Java, especially because our governor proposed me to chief of the COVID-19 treatment in East Java. I would like to present about the philosophy of the SARS-CoV-2 infection pandemic. Number one, this infection is human-to-human transmissions. This is very difficult how to protect it. Usually, the airway droplets such as cough and sneeze and close personal contacts, touching or shaking hands, touching the surface of the content of the virus in our hand, touching mouth, nose, or eyes before washing of our hands. And the last paper, we can see that faces contamination maybe can be as a transmission of this virus. And SARS-CoV-2, especially, it's a new case. New case. Diagnosis and treatment process is still in the research progress. And it is the very important phenomena, super spreader. One case can spread fast and create thousands of the new cases. It is very important and this is very demanding. But this disease is like a viral infection, self-limiting diseases. So all of the phenomena, actually we are facing quite a two pandemic at our country. We know this COVID-19 itself and the stupidity because we don't know exactly about the pathophysiology of this virus and this new virus of new one. So it is very difficult to all of us how to manage this pandemic. But I think in this time, it is time to ask all of Indonesia citizens, what is the country give, not what the country give us, but what we give to our country to manage especially two pandemic, COVID-19 and stupidity of us. We can see from this data that especially in the 40th of May, we can see that the active phase and total cases already grow up, recover also to grow up, and then from the mortality. But lately, the mortality become increase and increase, especially in Surabaya regions. So if we want to see, and we see many countries that suffering from the pandemic, we can see that Malaysia, Italy, Professor Franco said, Germany, Thailand, South Korea, Hong Kong, it could win from this pandemic because we can see this is decreasing of the curve, but we can see USA, Singapore are already decreasing, even though it's in a high level. Indonesia, until now, we can see the graphic is still to the not decreasing until now. We can see this is very important. What should we do? How to make the graphic come to the line? I want to present about the East of Java. We can see that even though our cases in East of Java is more than 1,000, but the prevalence of the Java nowadays in the number 7, comparing with our province in Indonesia, 3.55 per 100,000 population. Sorry. This is our data distribution of the COVID-19 in East of Java. We can see that Surabaya, city of Surabaya, today we have 921 cases. So the color of the Surabaya is darkly red. So living in Surabaya today is very dangerous. Number 2, Sidoarjo, neighboring of the Surabaya and Lamongan. This is Magetan and Malang. But we should be careful in Surabaya. Totally, in the 14th of the May, we could have case 1,858 confirmed, and treated in hospital 1,384, 75 49%. And this is the disease or death case, more than 9.69%, and this recover patient. And we only have high suspected patient, more than 4,000, and suspected patient, more than 21,000 patients. And then this is very important, without symptom. Without symptom, especially in the young men, more than 20,000. Symptom that rising is confirmed case in East Java, we have 1,028 case data on May 9 on May. We know that the cough and runny nose is the most prominent symptom in East Java. Comparing with the in China, Shanghai, Wuhan, the most symptom is fever. But in our province, cough and runny nose. Comorbidities, it is very important, like Professor Franco's presentation. In our patients, we have 1,281 data. Hypertension, heart diseases, and the diabetes mellitus is a very common comorbidity in our patients. We know that mortality is very, very correlated with the comorbidity of these patients. So in that way, maybe our mortality rate is still high. This is our referral hospital. Now we have 99 hospital for referral of this COVID-19. And then we have 2,049 isolation with the 61 negative pressure with the ventilator and 258 negative without ventilator. We can see that ventilator is very important thing to support when the patient getting worse, especially when the patient in the press of the respiration. Our management, especially in East of Java, we have 3 T. The first is test, the second is track, the third is treat. Test, it means we have a rapid test with antibody examination that Professor Kenji Ohata already discussed earlier. And then we test with the antigen test with the RT-PCR and antigen rapid test. After we have tests, so we continue to the track of the patient. Track, it means case finding and isolation. Isolation of who positive in the test. Isolation of the surrounding people that very contact with the patient. And then to treat, include the medical treatment and social safety net. Social safety network is very important because isolation, so everybody cannot work, and then we need for many things to stay alive. So isolation, it means a social safety net is very important. So we can summarize that we have 3 kinds of the efforts: health efforts to make tests, clinical tests, radiologic tests, and confirmatory tests, health effort, and then medical treatment, and then preventive effort, how to get isolation, how to make health, life, and then funding efforts. Funding effort especially for social safety networks. This is our activity in East Java. We can separate into 3 kinds of the activation. Health effort, we have 11 laboratories for PCR and then 49 for gene experts. It is still in progress. 99 referral hospital for COVID-19, and then building emergency hospital in Indrapura. Increase hospital capacity like Sutomo Hospital, like Airlangga Hospital, Menur Hospital, increase the capacity. We hope all of the hospital in East Java increasing the capacity to care the COVID-19. We have 7,380 observation room in each village, all on the East Java. Each village, because we need isolation, it means isolation in the observation room. Increase the number of medical devices. Funding, yeah. Funding activity for curative activity, it's been more than 55 billion, yeah, 55 billions. And then preventive and curative activity, we promote health protocol and social media, all of the social media, media massa, mass media, in the radio, very popular radio in Surabaya, as well as SS, localized effort in the neighborhood and regional government, and total fund for preventive activity about more than 7,000 billions. It's come from East Java government and then supported by the National Rescue. For preventive effort, we have protective suites, masks, RTD, RT-PCR for all of the doctor, all of the medicine who take care of this COVID-19. And partially lockdown or PSBB, large-scale social restriction, started in 28th of May. Active surveillance regarding healthcare status, social condition, and economic conditions, especially it is done by the Dinas Kesehatan Provinsi Jawa Timur, and public health effort, environment, nutrition, and psychological support. Social safety network, it means support to all of the people that suffering from the COVID-19. Total fund for social safety net is very large, more than 66 trillions dollars. And we also have planned if the patient getting limited or decreasing of the curve. So we have a plan to before exit and then exit strategy and then review of the strategy. We can see from. And then practically in the east of Java province has 4 teams. The first team is promotive preventive cluster. Second team is tracing cluster and curative cluster and social economic impact cluster combined. Because the most important thing is social economic is conducted by our vice of governor and curative by me, tracing by the Dr. Kohar, and promotive and preventive cluster by the chief of the National Rescue. This is our budget, especially we can separate for social safety net, recovery, promotive, preventive, and for curative. It is very, very, very huge. This is our timeline on the COVID-19 handling at East Java. It is presented by our governor in the Paramadina University webinar seminar. This is, we start in 3 March and then continues until 28th April, implemented of PSBB in Surabaya, and then extension of PSBB in Surabaya started in 25 May, and then PSBB in Malang on tomorrow. This is our activity when in promotive and preventive activity. There's many things we already done, like disinfectant spraying, and then all of this is the Masjid Al-Bar, disinfectant on this area. And this is large-scale patrol. Almost every night, we do large-scale patrol to the cafe or to the area that many people come to there, and then continued by the repeat test in the crowded area. This is our governor, and this is our chief of the police in East Java. This curative activity, we have many things to already done. So, this additional facility and infrastructure, including repair and emergency isolation room, and also including Sutomo Hospital. Today we have 61 isolation, and Airlangga University, especially in the infection hospital and Airlangga, supported by Professor No and other company, and by government of East Java, maybe more than 200 will more than 200 beds. This is our emergency hospital. Today, the capacity of the emergency hospital in Indrapura, 200 patients. We also has resources. It's about 410 volunteers. It consists of doctors, nurses, and pharmacists, and others. It's to support us to operate this hospital. The isolation facilities in rural area, we have more than 2,000 of the more than 8 villages have observation room. This is our application to support all of the activities, how to manage the COVID-19. If we want to know something about the pandemic of COVID or about the COVID, you can call layanan call center. If you want to assess yourself, is someone getting COVID or not, we can apply to self-assessment COVID-19. Yeah. If we want to discuss about our health or about how to manage if we suffer from fever, maybe from cold, this is COVID and COVID-19 Jatim, and then you can apply to radar COVID-19 if you want to know all of the progress of the COVID infection in East Java. You can see where the places that has many cases of the COVID, where the hospital is available for carrying the COVID-19. Yeah. This is our applications. Everybody can apply in this application. Today, almost more than 4 million, more than 4 million applicants using these applications. This is COVID-19 Jatim. Yeah, you can see that this red marker. It is what I mean. It is the density of the infection of the COVID. You can see that this Surabaya, almost all of the Surabaya, district of Surabaya, is the density of the infection of the COVID-19. So no place anymore in Surabaya actually. Radar COVID is very popular. You can apply this application. It's already visited with more than 5 million. Not only from East Java, it's from Jakarta, out of the Java province. COVID-19 real-time question and answer. Yeah, this is if you want to ask to me about how the manage of the COVID, especially when we have a family or we have someone getting worse with the fever or cough, you can ask to or apply the applications. This is also when we know that many students studying in the home, in the house, so they can learn about the COVID-19 interactively, word of hope, maybe hope or not, yeah, and take part in mutual assistance to help the community and medical personnel from home. It's like the game. Yeah. Jadi this game can be downloaded via the COVID-19 education game submenu on the East Java Province government website. It is very popular especially in children. Yeah. In children, the game. It is the game for charity, learning friendship. It is the last program, social safety net. It is very important thing because you know that we need isolation. Somebody can work outside of the house, so we support the living costs and others. Economic recovery, presentation and publication of art and culture in East Java, tourism rebranding, strengthening institution and supervision, marketing facilitation, strengthening access to financing, strengthening production and business restructuring, and strengthening human resources, especially in kooperasi. East Java Popla entering COVID-19, empowering is the company of the East Java, community economic enterprises, fostering term of the work, wage, and social security, labor-intensive activity. So this is our comprehensive treatment of the COVID-19 pandemic, COVID-19, not only in medical aspect, but in the social, economic aspect and other. I think it is enough. Thank you very much. I'm so sorry, Dr. Asra, because in the fall, go to the
Okay. Okay, thank you, Dr. Joni. Yeah. So I think this is the last presentation. So we start for discussion and question and answer. Please, Professor Bajamal, if you have any question. Professor Bajamal.
Yes, thank you very much, Professor Ohata, Joni, presentation, and also for the speaker. Thank you very much. So actually, my question is for all of the speakers. Since usually there is the same problems, and I hope all of the speakers will choose except Dr. Franco. Now, my question is first is.
Please, Professor Bajamal. Your voice is
yes.
not very clear. Yeah, please.
Now it's
louder.
Clear?
Yeah, louder.
Okay. Thank you very much for the presentation of all the speakers, Professor Ohata, Dr. Joni, and Dr. Nasronudin, Professor Djoko, and Professor Franco. Thank you very much. It's very impressive and very beautiful presentation. Now, I have learned from this presentation. But I have still many questions. I hope one of the speakers or all of you can answer my question. The first question is to Dr. Joni.
Please,
Dr.
your voice is too.
Yes,
too big.
the first
Yeah.
question is to Dr. Joni and Dr. Professor Nasron and Professor Djoko. Do you agree if our government adopt a strategy of herd immunity? Why my question is because, you know, in our country, we have many cases with the TB patient. We had many cases with anemia. We had many cases with undernutrition, and 30% for the population is old patient. We have limited hospital bed. We are not the same as Japan, so we have many limited facilities. And that is my first question. And the second question is about postmortem tests. Professor Franco explained about the postmortem test. So because of that, they know exactly whether the patient died because of COVID or not. But because many patients died in our country now, is only suspected of COVID. And then they manage the body of the dead patient as a COVID patient. This is terrible for the family. How about this? Do you agree to apply now the postmortem PCR to the patient? That is two questions. The third question is, we're still facing a rising of the COVID cases, according to Dr. Joni. Now, Professor Franco told us that in Italy, they trained another doctor, also a neurosurgeon doctor, trained for intensive management of COVID. They trained for only 1 week and they can manage. Do you think now you can start to train our doctors for emergency cases of COVID? Okay, that's my third question. Thank you.
Okay, Dr. Joni, mungkin maybe you can answer some question and then continue with Prof Nasron or Prof Djoko, please.
Yeah, thank you very much, Prof Afid, for your questions. The first one is the herd immunity implementation in our country. I do not agree about these methods, but we know that there are no one magic bullet to treat the COVID-19 because it is the new diseases. This is the disease with the complex of the social problem. And then we have many people who are suffering from the comorbidity. So herd immunity is very, very dangerous in our country. Our solution, maybe we will propose to our government, is the mixing of the social support, especially for social economic support to the people that suffer from the isolation. Yeah. Isolation, it means they separate from the surrounding people, that they cannot work to overcome the daily needs. Yeah. So government should be support, and then implementing of the strength of isolations, physical isolation, social isolations. Yeah. So it is very important. And the second, the question is, I forget the question. The second question.
Postmortem swab for diagnosis.
Yeah, postmortem swab actually is very important because we will know the exact number of people that are suffering from this COVID, and from this data we will learn many about the management of the COVID. And the third is training about our resident or our.
So Dr. Joni, so for postmortem, you agree to do the postmortem test for our patient?
Yes. We already did some test for some people actually, because when we don't know exactly, number one, we don't know exactly the diagnosis of the patients, it is problem in the insurance. Number one. Number second, we know exactly about the diagnosis, and then we can make a proper isolation for the surrounding people. Yeah, isolation in surrounding people that suffer from COVID-19.
But this is until now not yet generally doing.
Yeah. Tapi because some places done that, some places do that. And the third, actually, government from the health department and then Center of National Rescue already arranged about the guideline how to manage the COVID, how to protect ourselves with COVID. So every doctor, every nurses, and every trainee should read this guideline. And this is very clear how to protect when we manage the COVID-19. I think this is my opinion.
Okay. Thank you. Prof Nasrun, how about the herd
I'm so sorry, Dr.
Okay, thank you.
Because we have
Thank you, Dr. Joni.
Ready.
Prof Nasrun, about herd immunity.
Thanks, Professor Habib Bajamal, for your good question about management of COVID in Indonesia. Basically, can 3 ways to stop COVID-19. So this one in India is vaccine and drug of choice, but that is need to more time. So while we are this decision, if potential effective herd immunity is very horrible. So based on basic reproductive number is very dangerous. Yeah? So if 1 person to transmission to 2 person and 3 person, if very dangerous in population. Maybe in 50% if to 1 to 2% and 60 to 67% is in population is very dangerous. So decision of our government involve extraordinary restriction on free movement assembly as well as aggressive testing to interrupt its transmission. And I think we agree why to need to vaccine and drug of choice.
How about the training all the doctors? What do you think?
I think so important training, because through this training, the doctor will get some refresh of the basic pathophysiology of the biology machine, like hypoxia, silent hypoxia in the COVID. Why silent hypoxia? Each of the doctor can explain why silent hypoxia occur in the body if the patient can get the COVID-19. This is so important because if the real hypoxia related with the symptom of the dyspnea, but in this case not dyspnea because comparison high concentration oxygen and PCO2 difference. In the reality, PCO2 can cause can give sign on the receptor in the brains. But in the COVID-19, when hypoxia, the PCO2 so normal. Because of that, the patient like no problem of the oxygen. If the doctor get a special retraining, I think is a good. I think increasing for the capability, also skill. So please, Dr. Asra, through the director, to support for the retraining.
Professor Djoko, if you agree with this, it is a voluntary of requirement for every doctors.
Oh, I agree, Prof. Because
it is a requirement of only voluntary.
Requirement only voluntary. Yeah. So like the post for the retired doctor like this, or the other doctor maybe, you mean, Professor?
I think for the doctor in hospital, yeah, if they are not pulmonologists and you will train them for the intensive COVID. Yeah. It is a requirement or only for voluntary?
Oh yes. If in the certain case, I agree, Prof. As long as the pulmonologist cannot cover all, so the other doctor have to support to anticipate for the case, Prof.
Yeah. Is it requirement or voluntary?
It's requirement.
Requirement. Okay. Thank you. I have one more question, Dr. Asra.
Please.
To Professor Djoko and Dr. Nasronudin. This about the plasma therapy. I'm still confused. This is, you mentioned about, this is an old technique already available in 100 years, Professor Djoko, you mentioned about that. But until now, there is no convincing research, especially for COVID. And if we apply this plasma therapy, we are too brave to apply this technique actually. Yeah. The risk is, we don't know exactly how much is the risk if we apply this. What is your opinion about this?
Yes, yes, Prof. Thank you so much for your good question, Professor. The plasma, so many items of the enzyme, also the other protein and others. Yeah, that until now is the mystery. Because of that, if we use the plasma therapy, have a special condition like in the supercritical ill, Professor. And if used for the plasma expander, please remember about the side effect of the plasma therapy, like the acute injury in the lung, like overload, like the reaction anaphylactic, like the hemolytic and others. Because of that, it's so unpredictable appear of the side effect. So the doctor have to pay attention and be careful for use for the plasma therapy. I think that's all, Prof.
What do you call opinion of Professor Nasron about this? Professor Nasron, what's your opinion about plasma therapy? Do you apply in your hospital?
Yes. Now is ongoing research about plasma therapy, and principally we agree with plasma therapy in our hospital, especially in severe COVID infection, in severe condition COVID infection.
Yeah, okay. And one of my question about post-COVID, about the postmortem COVID tests, do you apply in your hospital now? In every cases of death, you do PCR test for COVID?
Oh, until now, postmortem still not yet.
Not yet. So how do you know that the patient died with COVID or not?
Based on a specific examination through CT scan. Apa namanya?
Okay, okay. I have one question for Professor Ohata. Is it possible, Dr. Asra?
Plasma treatment. You're asking me plasma treatment in Japan?
Yes.
So I don't know the detail of this treatment, but we have some news. Patient recover from the COVID from the treatment, but it's not so common in Japan. Not common. I'm not sure, but we have now such as severely sick people getting less. Can you hear me?
Yes.
I don't know the detail of the plasma treatment. Just I know it in the newspaper. I'm sorry about that.
Yeah. Well, Professor Ohata, one more question. So I'm congratulations, because in your country with the home care hospital facility is very maximal, and your culture in Japan also support this management of COVID. But you mentioned about the possibility of BCG vaccination.
Yes.
And I need more information about this because we still use BCG in Indonesia now. Is that
really
true, Dr. Nasron?
It's a national program. All children must have the BCG in Japan.
Yes. And
do you have the same system?
I think Indonesia still use BCG also, Professor Nasron. Right?
See.
BCG vaccination.
Still use.
Yeah.
Still use it.
Yeah.
I think still use in Indonesia.
Yeah.
Okay? Yes, we still use, Professor Ohata.
So as far as I check the literature, strain is important. You must use Japanese strain. It's very effective. Yeah, strain is very important. So I'm not the specialist, but as far as I check, strain is very important. Which strain you use? This is you must select the good one.
Yeah. Okay.
Thank you, Prof.
Thank
Hatta.
you. Prof. Hatta, thank you very much.
Prof. Rita,
Yeah.
maybe this is the last question. You hear that the condition in Japan is very very different from our country. Do you have any comment or question to Professor Ohata about this condition? Yes.
I think it is a consequence of how the habit in Japan. I already read it in one of the journal that the habit was to not just shake hand, but just bow and just to yes, it is good. And then just let the shoes outside the front door. It is good.
Yes.
But I would like to comment, especially for Dr. Hafid, Professor Hafid's question, and also about what Professor Franco said. Everybody can cure, not to involve in the treatment of the severe COVID patient. In Indonesia, Prof. Djoko, we have already a decree about who is the other specialist beside the pulmonologist and intensivist that get the competence, special in this period, to be a doctor in DPJP in Indonesia, in intensive care. And as long as I know, it's only 4, and without the surgeon. I don't know why, because it is the college decided it. It is the internist, pediatrician, and pulmonologist that have the special special allowance to do the same work as an intensivist, but not the surgeon. But so if the Prof. Nasron will allow the surgeon work, then he has to make a special request.
Problem.
Yes.
Not clear.
It's okay. For us, it's okay. Many people can work to help the COVID patient. It's okay. But there is a law that still limit our niat baik. That's my comment. It's okay. Finish.
Professor Ohata,
yes,
Prof. Rita said that the culture of Japanese people make it, a good advantage.
Yes, I think so.
Condition.
Culture,
What do you
we
think?
have just bow, bow. I don't know how many times I bowing a day.
But Professor Hatta, I hear in the TV that there's still more city that just locked down.
Yes. So Tokyo and Osaka, we don't like to say lockdown. So government still continues a state of emergency in such a big city. And it is actually the infection rate is getting very low now. But government very much afraid of the second wave, like Germany and Korea. They are very conservative. We all Japanese people can understand the government is thinking about. So even after lifting the state of the emergency, I hope people continue to stay home. But we have some psychological problem. At home, I must miss my wife for so many of us. Sometimes I want to go outside, so it's so, we are human beings. I'm not sure how much I can be tolerant to this problem. So we need to have a new lifestyle. So this, I'm looking forward to having this webinar seminar because I have an opportunity to talk about. I can opportunity to open my mouth.
Good for you.
Good for my health.
Okay.
So it's
Thank you.
meaning Japanese people continue to stay home.
Until now.
Until now. So I think I hope Indonesian people may follow Japanese way.
Okay. Hope so. Okay. I think it's the end of our webinar conference. So Thank you to all the participants, everyone who joined us for today's webinar, and also to Professor Djoko, Prof Nasronudin, Dr. Joni, Professor Ohata. Once again, thank you, and Professor Servadei. Thank you for sharing your insight and expertise. Thank you very much. Yeah. Stay healthy, stay at home.
Thank you.
Please, I give to the host.
Okay, thank you. This is really a great time to discussion with all of you that attended today. And this is the end of our Universitas Airlangga webinar conference. I hope you enjoy for our great discussion. Thank you so much for our honorable speaker and also the moderator. And we inform that the certificate will be sent to your own email that registered on the registration form and by evaluation for your timing of attendance. And don't forget to fill in the post-webinar survey. We apologize if there are some mistake or some misunderstanding or maybe some question that we cannot answer one by one because the time is up. I'll see you next time and please stay safe, stay healthy, and stay home. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. I'm Dito Darlan. I will catch you in soon.
Thank you.
Thank you very
Ohata
much.
Sensei. Sayonara.
Looking forward to seeing you again. Bye bye. Thank you.